Here's what happens in open space. Participants, all of you, get to convene a session on topics that you want to address. Questions that you need answered, offers and stories that you want to share, requests that you want to make of others, or topics that need further discussion, even if they've been brought up already in the committee, in the other sessions yesterday, for example. So process that for a second. This is the notion of you getting to say, this is something I think we really need to further discuss. And here's how it happens. We have room for multiple groups and tabletops in the room here. We're going to have it all in this room, and we're going to assign locations to the different topics and have tabletop dialogue, and then we're going to have report outs back into the whole room for a conversation of the whole room. Okay? So people are understanding where we're going with this? The how is the next part of this. I want you to think about and decide if you want to convene one of those tabletops. Yourself, your topic, you're part of the leadership, and we're going to co-do this together. We're going to co-create. Okay? So we will all have both ownership and responsibility for going back. So the other phrase is, one of the impatient side of our whole collaborative history is, so what are you going to do by next Tuesday, right? In other words, there's things to be done, and sort of waiting the traditional 17-year lag before something is already published and actually in practice and disseminated throughout the nation, I don't think is ethically acceptable, okay? So part of the question becomes, what's compelling ethically to push on to get going on as soon as possible? That's part of the passion, right? So decide if you want to convene a session. Create a 5-word title to it. Here's where it gets sticky, because invariably we get some people who want to talk for a long time and try to lobby for the actual topic, and some groups are tolerant of that, but some people as a group decide, no, the rules are 5-word title or less, and we want you to get up and say a 5-word title or less. I'll leave that up to the group as a whole to decide how strict they're going to be about that. The conveners will line up or stand up, and we will run a mic to you, and we will ask you to say the title. So essentially, we're going to ask you to either raise your hand or stand up when those of you who have decided to offer a title want to show that to the whole room or say it to the whole room. And we will hear those titles, and we will designate a place for you. We've got staff here who's going to be helping me do this together. We're going to do this as a team. And the question really is, did you come up with an interesting, pithy, 5-word or less title that sells to the markets to the whole group your topic? So it could be that it's really important to you only and nobody else. That's a possibility, okay? So please factor that in. And then we have some really kind of other possibilities. And invariably, people come up with 20 zillion questions around how to answer the things that are popping in your brain as issues. We'll talk about that a bit more in a second. When all the sessions are named, then the audience as a whole, the participants, will vote with their feet by going to the particular tabletop that they choose. Democracy in real action in this room, okay? Lots of problems, however, come up in preparing for this in your head. It's really more in your head, by the way, than in practice. I'll show you what I mean in a second. The idea then is that tabletops will happen. We'll talk for about 45 minutes, so it's going to be an in-depth discussion in the tabletop, and then we're going to ask a share out back to the room as a whole. And by the way, when you get to the tabletop, self-organize. One of you can decide to be the leader, one of you can decide to be the recorder, one of you can decide to be the reporter. The same person could do all those roles. I don't care. You guys run your tabletop the way you want to, okay? If you just want to tweet out from it, that's cool too, okay? Whatever you like, because it's really a question of what's important to do from your point of view, not just talking about the topic, convening the tabletop, but actually how much do you really want to share this out to everybody? in the details of all this. Questions and possibilities. What if no one comes to my table or my session, right? Biggest angst that happens in that. That's okay. You run a table of one if you want to, because you know, you may be completely right, everybody else could be completely wrong, right? We want to have your thoughts on this. However, there's other combinational possibilities. Like, for example, can participants roam around? Yeah, why not? So if you go to one tabletop for the first 20 minutes and then switch, that's allowed too. Okay? Because you're voting with your feet. You're choosing to engage, and we're not structuring you to have to be, you know, sitting bored at one table if you already got your input into that discussion. So you have complete ability to do whatever you guys want in this whole process. Other question is, so how do we know when a session is done? Easy. Everybody stop talking. That's it. Done. What if we have identical or similar topic? Mergers are allowed. So mergers and acquisitions are allowed. Again, it depends on how well you convey your topic. So if we have 2 or 3 people speak up the same topic or similar topics, you could actually, and I've seen this happen a lot, on the spot, just by eyeing each other across the room, you sort of decide, let's just co-lead this thing at this next table, wherever it gets designated, right? No problem, because basically, why have people frustrated that they can't go talk with somebody else they really want to go talk with? Okay, so the real question at this point is, what is your short title? We'll ask you to engage the microphones. And I'll give you a couple of quick examples. So titles, for example, establishing effective community engagement. You notice there's a trick there. Community engagement has a hyphen. That counts as one word. English is funny. We can do this. Exchanging outcomes, evaluation, ideas, / methods. A slash counts into one word. Okay? I've had examples of this for a long time. So to try to prevent people from getting up and arguing for whether the hyphen or the slash counts, we just make it part of the rules nowadays. Conducting evaluation measurement, again, makes it a long but one word. What can we do fast? Okay, so the titles could be very detailed or very broad in concept. All right, are you guys ready for this next step? All right, let's ask we have a voluntary, really amazing person willing to be a scribe, which is really scary. That's the idea that she's going to type in front of everybody as we have this happen live, okay? So in other words, come on up. So Steph has been willing to come up, and as you say your 5-word or less title, she's going to type it. We're all going to co-process this together and see how many tabletops we're actually going to engage in. Okay? All right. Do we have the mics ready? Okay, mic 2, 3. Raise your hand if you're interested in running a tabletop. There's the first person right here. And please say loudly the name of your 5-word title or less.
Elements of a shared data depository.
Elements of a shared data repository. Is that 5 words or less? Shared data is 1/word. Okay, got it. Over here.
Strategies to maximize personal accountability.
How many words is that?
Take out the table.
Oh, super. You guys are good. Okay, over here. Right there. Sorry, I didn't get over there yet. Go ahead.
Behavioral health and community wellness.
Behavioral health in community wellness. Good. Over there.
This may actually go with the first one, and I would
Whoa. Way
accept
too many
a
words
merger.
already.
Yeah.
Just say the 5-word or less phrase.
Merger is coming here. Integrating data systems for population health.
Integrating data systems. You're suggesting that has similarity to the first one?
Yes, it is, and I would accept a merger, as I said.
Is that acceptable? Super, we got a merger on the fly here. Over here.
This might be a friendly amendment to that one as well, but leveraging data beyond health?
Leveraging
Healthcare?
data beyond. What, do you mean leveraging data beyond healthcare or beyond health?
Leveraging data, well, our original title. If we use some acronyms, it might work. Leveraging data beyond PH for public health / healthcare.
Wow. Is that less than 5? Huh? Thank you. Over here.
Providers / practice, culture for health.
Provider slash. Over here.
Merging wellness into clinical pathways. I'm also willing to accept a merger.
Okay. No, wait, that's good.
Or integrating wellness.
Wait, now you got way too many words. Now you're lobbying. Go ahead.
I'm not willing to take a merger. I want to make my session first. So mine is engage in immigrant and diverse populations.
Oh, say it again?
Engage in immigrant and diverse populations.
With an S or no?
Immigrant / diverse. That's one word.
Oh, that's 4 words. Or 3. Okay, thank you. Anybody else? Oh, here.
Health system upstream prevention realignment.
Health system. Is health system one word?
I don't think it needs to be.
That's still 5 or less, so you're good.
How to find helpful people.
I like it. Okay, now, this is what's interesting. Let me just say what the elephant in the room is, okay? At the beginning of this, you guys thought there's never going to be enough people standing up to do this. And in fact, we're going to have more than 10, right? That's just the current prediction. Let's go to her over here.
This also might align with other things, but multidisciplinary partnerships measuring impact / value.
Did you get that? Could you repeat that again, please?
Multidisciplinary partnerships measuring impact / value. I think multidisciplinary can be one word, so.
Okay, that meets the rules. Go ahead.
Good morning. The deciding database / measuring impact.
What are we up to? 12? 13. Okay, go ahead.
Economically practical, healthy housing innovations.
Practical. Nice. You guys are good at this. Go ahead.
Listening / engaging the apathetic / adversarial. And right here.
Well, I don't know now because there's at least 2 of these I want to be a part of. But I'll say physical activity, a wonder drug.
Huh. Okay, let's just stop for a second and review where we are. We've got, come on back, and let's read them out. Hedge, I'll have you read them out.
Elements of a shared data depository, strategies to maximize personal accountability, behavioral health and community wellness, integrating data systems for population health, leveraging data beyond prime pH. Public health, thank you guys. Public health and healthcare. Number 6, providers / practice culture for health, merging wellness into clinical pathways, engaging immigrant / diverse population, health system upstream prevention realignment, how to find helpful people, multidisciplinary partnerships measuring impact / value, the deciding database/measuring impact, economically practical healthy housing innovations, listening/engaging the apathetic/adversarial, and physical activity, a wonder drug.
Okay. So that's interesting so far. Go ahead.
Paris Agreement, what to do.
Okay, now that's a... All right, so now we need to decide where we're going to be having these. And basically, if you could all, okay, does anybody want to actually merge? Should we, that's one question. 1 and 4? So we could just cut and paste and copy it together. See, it's tricky to do this. Copy it. This is why it's scary to do this in front of everybody. You're good, by the way. Nice. Okay, so this could be completely random. So who's topic 1? Raise your hand. And 2? Let's put you over there in that table over there. So I want you to get up and walk over there and stand next to the table. Topic 2? Where is it? Oh, you're here. I want you to come over here to the middle. So the point is, I know some of you lobby locally around your actual current table, but you have to get up elsewhere and do it. Topic 3, we'll move you over here to this reserved table. It was all reserved for you. Topic 4. Okay, if you can come up to the front to this table in front of you. Oh yeah, it's 5. Yeah, so it's really the new 4. 5 is the new 4. Next one. This becomes, 5. Who volunteered for that? You did? Okay, you can just stay there, and we'll have you simplify your lot. Okay. Next. Who's running the next one? Sure. Okay. Actually, that's a good point. Let's back up for a second. Up to the, we're almost halfway through this piece here. So the first one is elements of a shared data repository. Yeah, integrating data systems for population health, right? The data repositories over there. Strategies to maximize personal accountability. Where'd that go? Right here. Behavioral health and community wellness. Here. Leveraging data beyond public health and healthcare. Over here. That's good. Oh, your marketing. You put the name up on your, that's really cool. Provider practice culture for health, right there. The next one is merging wellness into clinical pathways. We can have you stay right there. Okay. Engaging immigrants, diverse population. We can have you stay there. Okay. Health system upstream prevention realignment. Also, you can have you stay here. And how to find helpful people. Way back in the room over there. He's got a little advertising thing going on too. Okay, so now what we want you to do is to actually decide on which table. Who else wants to? You guys are tough. Okay, let's keep going. Multidisciplinary partnerships. I thought we still had a lot of room in the room. That's cool. There's a voluntary merger. So 10 goes to where? You're canceling your table? What if you got like, a lot of people wanted to come to your table already? You can actually start the tabletop, and then the whole group can shift and merge into another one if you want to halfway through. That's a option, and we can run it right out of where you are right now. He's got that table already? Huh? I thought you were in the back. Okay. Are you going to the how to find helpful people? Because that's a really good help. Okay, number 11, right? Deciding database measuring impact. Where's that? Okay, you can stay there. I think we're filling in the room now. Economically practical, healthy housing. Okay, he's got I thought it was a name sign already. From here, it looked like that. That's good. Economically practical, healthy housing innovations. Who's that? Is that you? Who had deciding database measuring? Oh, I missed the shift. Okay. So is economically, is he staying there? Yeah, he can stay there. Listening / engaging the apathetic / adversarial. You can stay there. That'll work out fine. Where would you like them? On the corner. Okay. If the leaders could begin shifting now, because people will associate, we will, but I want people to start seeing the individual who's leading to shift as they are, those that are decided. Also, that way I know where you are. One more. Physical activity, a wonder drug. That's you. Where would you like to be? I think you're going to have to go back here, right? That table's open.
That whole back row, it doesn't have anybody.
Okay.
You can sit anybody in the back row.
Oh, that's good. Okay. Does anybody have any questions as to where they're going to go? Okay, go. You have 45 minutes of discussion, and we're going to talk back to the group. So find the person that you want to join their table. If you have questions, you can come up here as to how we can help you find the right table that you're interested in. And go. Okay, let's see if we can come back together. If you can hear me, do another clap, please. And if you can hear me, could you do 2 claps? And then finally, if you can hear me, 3 claps, fast. Okay, so now we're going to engage into a conversation of the whole room. That there are different ways that people are going to be reporting out. The first one is going to be the following. Now listen carefully. It's hard to stop people talking with each other. So one little known secret. Introverts can talk more than extroverts if it's on a one-to-one basis. It's very hard to stop them. Because they say they're shy about talking, but that's not true. They're shy about talking in front of a lot of people, but they're very, very intense about one-to-one kinds of dialogues. So, and this is proof, because you guys felt to me like heavy introverts initially at first, but you guys are talking like crazy. This is really interesting. All right, here's what I'd like to hear. I would like to invite out those that want to share out one of those insights, except I'm going to make an amendment, which is I don't want you to share your insight. I want you to share the person you were talking with's insight, which is a bit of a test of whether you were really listening to that other person. So there's two ways to do it really quickly. You say, this is the person I just talked with, or maybe even just met, and that person shared this insight, and I would like to say this because it really caught my engagement. Okay? You hear that? It's a little more complex, okay? So you can share out to the room something you just heard from the other person that really, really feels to you like it should be shared out to the whole room. And we're going to get a spattering of these, and then after that we'll get actual report outs from the different tabletops. Okay, so we'll do 2 cycles of this, and then we'll get into a conversation of the dialogue together as to what does that mean for us as a whole national meeting. Okay? So let's say, if you could raise your hand. Actually, do we have the mics around the room? Oh, where's Karen and the other people? Okay, so we need to run the mic to people who really want to share. So we'll start with you. So you're going to share something, a key insight that you just heard from someone else. And if you want to introduce the other person, that would be super.
Okay, so Kalita is the one who convened this group, and she's from the Virginia State Department of Health, which is my neighbor. I'm from Tennessee Department of Health. I'm Tanae Franklin. And one thing that she started off the group with discussion was expressing her concern for being the only person, or sort of being the champion, if you would, of having to think about cultural competency, humility, or engaging diverse populations. So she felt the pressure of carrying that badge, if you would, throughout her work in public health. So that was a large part of our discussion today. Did I capture that correctly? Did anyone else at the table want to add?
No, nope, can't do it.
Oh,
it's not a
I
table
apologize.
discussion.
Okay.
This is a insights report out.
Okay.
That's different exercise. Okay, over here. Do we have a microphone over here?
So my name is Bill Barberg, and Janelle was sharing in their group. They were talking that the fee-for-service model still makes it hard for healthcare providers to really commit to population health. But there are a lot of other stakeholders in the community who have a lot at stake with healthy communities, and they talked about engaging large employers as being really key stakeholders in trying to build healthier communities.
Very good. Another person who wants to share out an insight that they just heard from someone else.
And I would add sort of the critical extra component coming from the behavioral health table is making sure those data systems can report accurately out on behavioral health claims, because there's a whole set of rules and methods of analysis that are unique by diagnosis, place of location, et cetera, but using data in ways that make it readily accessible. We've got to shorten the lifespan on those data integration activities that are all going on in many of the states around the room.
I was introduced to the work of the group on working with adversarial people, and I won't spoil their super easy to remember 4L system on that. But it was really interesting. I'll tease it by saying that one of their issues is be very careful about the language that you use, because there are trigger words that are out there that will take people out of the space where they can actually meaningfully relate to you.
Very good. All right, I want each of the different tables to be ready to speak from the table discussion, and we'll go in the order in which they are numbered. Okay, so let's start out now by saying, what did table number 1 want to say after all that discussion that the room as a whole could benefit from hearing?
We had 2 elements. My challenge was to try to figure out, in working with 3 independent health systems, how our health district could build a data depository that a funder is ready to fund if we can figure out how to do it. So what I wanted to do is distill down some ideas on best practices in building such a repository. And some of the suggestions that we got, we had a really good mix of people at our table, by the way, some very expert people from all over the country with different backgrounds that couldn't have worked any better had we designed it ourselves, I think. One thing we were told is that one of the best practices would be to build in the ability to extract outcomes. This is good for working with government, for finding additional funding, and for planning future programs. Using data to predict health condition clusters, predictive epidemiology, looking at neighborhood clusters, and also suggestions on how we look at the existing data we have differently before we build a new motor, so to speak. Standardizing data and the process for collecting it is essential. Don't use the word database when working with partners, it scares them.
Question on that. What do you use instead of database? What's the right jargon?
What is our term?
Knowledge base?
Knowledge utility.
Okay, interesting.
Just mumble database. And we need to be uniform in the way we input the data and extract the data so that we're talking apples to apples. We need to consider what's in it for everyone. Just because we're the health department perspective doesn't mean that's the way our database operates, but to take into consideration who our partners are and how to get leadership, be it municipal or governmental, to understand the importance of doing this. And then from your perspective?
Well, thanks. I very much concur with that. And the original question that I asked was this: how do we bring together in our respective states the computing and data resources to effectively understand and build community and population health? Got that? And the point being is that we're really looking at what's currently experimental and fragmented, and over a period of time really needs to come together in some kind of a much more integrated planning. And that probably is the issue that has to do with leadership. We know that IT people can do just about anything that you ask them to, but it really has to do with the leadership and the direction of those resources toward the public and the common good. And believe me, there's a whole bunch of policy and cultural things that are engaged in that, as you undoubtedly know.
Who wants to share out from table 2? Oh, what was the topic?
Strategies to maximize personal accountability.
Who wants to share out from that table? Table 2 is being secretive.
No one wants to talk about personal accountability.
I'll just, we actually, there was only 2 of us, so we broke up and went to join other groups. But briefly, we just talked about how to, ideas for how to hold the population accountable when you're doing initiatives. And so some of the ideas we just had were engaging payers and primary care physicians to engage with the patients in different ways.
Very good. Table 3.
We were at the behavioral health table, behavioral health and community health. We sort of had a wide-ranging discussions. One of the sort of larger recommendations was we need a separate discussion on this, or to merge our thinking with other activities around this for a longer period, whether that's another conference or another track. We'll leave up to the conference planners. Social norms for alcohol, social norms for marijuana, social norms for opiate use. We felt around the table that there's got to be a sort of real rethinking of the social norms that we've got operating in our communities. I was walking down the street to digress and hearing some kids behind me talking about blacking out at the third shot last night, and they were all laughing how fun that was. We've got to change that dynamic. We've got to change that where it's not something we share and laugh at. Organizations and financing. Everybody was talking about sort of how things are organized, and that cuts into and inhibits effective interventions and activities. The need for diversion for behavioral health individuals, diversion from jail, diversion from emergency rooms, diversion from other sort of levels of care into more appropriate settings, whether it's crisis diversion units like California and other states are setting up, or into self-help. Telemedicine, chaplaincy, EAPs, how to sort of think about services, and I'd add self-help, how to think about services earlier in the sort of in the service curve, if you will, outside of the professional sort of boundaries. How do we use faith-based communities? Chaplaincies was described in North Dakota, for instance. How do we use EAPs? When a physician screens, SBIRT was one of the sort of other key discussions, screening, brief intervention, and referral to treatment, widely accepted and recognized as effective in training primary care physicians and primary care practitioners in recognizing sort of signs of alcohol misuse, signs of drug misuse, and identifying brief intervention strategies. We're talking 10, 15-minute interventions that can be done to activate a person to seek help on their own, to activate a person to seek services, to follow through on referrals. Equally relevant, I would argue, to mental health as it is to substance use. We're just not very good in the mental health side about identifying what those brief interventions should be, because a brief intervention for most people trained in therapy is 5 sessions, not 10 minutes. And some of the solutions for that were exercise, mindfulness, social supports, and I would argue sort of motivational interviewing is a recognized sort of tool to encourage activity that way. And then we sort of spent some time talking about the broad sort of community wellness related activities and how wellness as a strategy, as a framework, changes the dialogue from mental illness and addictions. And all of us have got times where our wellness is not as good as it should be, I suspect. That's certainly true for me. And how do we sort of identify strategies in the health system, but in our broader communities and support those where, in fact, wellness interventions that promote wellness are part of what we do. Environment's part of that. Obviously, all the other sort of wellness activities, exercise, mindfulness played into that. So the discussion went round and around. I think those capture most of what we covered, and I will hand off.
Thank you very much. That was table 3, right? Yeah. Table 4? Forgot where table 4 was. What's the topic for 4?
Table 1. I would say that Table 1 didn't spend a lot of time talking about multi-sector data sharing, although some examples were described in terms of software that could be used by care navigators to navigate between healthcare and social services. Another thing that we talked about that is related is the role of health information exchange entities, and it seems like that there are lots of limitations, but perhaps some good examples in Iowa and Nebraska.
Interesting, thank you. Table 5.
Good. And at Table 5, our topic was the role of the primary care clinic. in the culture of health. Thank you very much. And we talked about that in two different ways. One was how we work on prevention within the processes of the clinic, such as diabetes care, colon cancer screening, and the role that the whole team of the clinic plays in making those processes successful, which trickled down into the role of each member of the team and making sure that the MAs and the front desk staff and the health educators and the social workers and the physicians and the nurses understand what their piece of the puzzle is and how every person's role is necessary to make that prevention effort successful at a population level. And we shared examples of ways that we helped some of these different roles understand the importance of the work that they were doing, and also some ways that, for example, MAs provide necessary and important information to physicians, such as the sort of gossipy information about who's had a divorce or what the outside of somebody's house looks like, and how they may not have necessarily realized that social context was really important to the physician understanding more about what the patient's life was like and how to best treat them. And that's information that sometimes other people in the clinic are more well suited to sort of pull out of the patients than the physicians are. So the whole team understanding that and bringing all of that information together is necessary for taking best care of patient and understanding their social determinants and social context. Regarding social determinants, we also talked about having a dashboard that was right there in our face as a primary care provider to help us understand, again, the context of the patient's life, and in our 15-minute visit, where our counseling might best help the patient. For example, if they lived in a food desert and we knew that, our counseling about what types of foods they should eat might be different than somebody who lives next to their local farmer's market. The second route that our conversation took was talking about the clinic as a center of health in the community, or sort of a focal point or a hub of health, and that if there was a culture of health within the clinic, meaning that the people who worked there were concerned about their own health, that the clinic or the hospital made the healthy choice, the easy choice, with biking to work and vending machines with healthy food and the salad bar being the cheapest thing in the lunch room, and a walking meetings instead of sit-down meetings, and a walking group at lunch, that if all of the people in the organization have health and healthy behaviors and healthy choices in the forefront of their mind, then that may spread out throughout the community. In addition, if we are healthy and well, then we are more able to take better care of the people who come through our doors. If they have a better experience of health care when they're in our building, then they may be more apt to follow our suggestions and get the screenings that we recommend. And so the clinic or a health system being a hub of a healthy culture, we thought is also one of the key ways that health care can create health and wellness.
Thank you. Okay, table 6. It's you guys. Oh, good.
So that's actually a great segue into the conversation that our group had. And we had a really diverse representation in our group. Folks from hospitals and health systems, FQHC, And so we had a robust discussion about merging wellness into clinical pathways. And it sounds like our conversation went in the direction of many conversations at several of the other tables. But some of the kind of the key insights from our group included building relationships and trust among health professionals. So personally, if we have a good relationship with our physician might be more attentive, right? And this happens in a lot of different ways. So building trust and relationships among professionals. Doing this can also elevate the role and credibility of wellness professionals. So that, just like the behavioral health group shared, that practitioners may be more likely to introduce services earlier and be proactive rather than reactive. We talked about inserting ourselves as health and wellness professionals into discussions and work groups about the development of clinical pathways. If we haven't been invited, we'll invite ourselves. Show up at the table. Also, demonstrate how certain costs can be avoided while financial gains can be made in other areas. And then finally, collaborate at every opportunity. And keep working really hard to spread the message about the importance of wellness and prevention in the work that we do.
Good morning. We spoke about engaging immigrant and diverse populations, and our dialogue took various routes of discussion. We moved from actually the population to actually bringing that diversity needed into the actual workplaces that we are, so that we have a full understanding. So we talked about in ways to engage those communities. First, we have to develop trust. It should not always be as if we're going into these communities to get something. We need to have a vested interest in the communities. We need to show them that we really care. We need to identify sometimes gatekeepers or people who are in those communities that can establish our trust. If it's always a number thing to meet goals, to meet deliverables, to meet objectives, people tend to shy away from that, particularly if they are undocumented. It needs to be something that we're helping them to achieve versus just us being the only one that's achieving or getting something from the discussion. We talked about, lots of notes, so I'm trying to pull out we talked about sometimes giving them something is not necessarily, getting them to our clinic, but maybe an ID. An ID for somebody who's undocumented may mean a world of difference. So being able to have them leave with something tangible to make them feel like they belong, to make them know that we are genuinely concerned about them. And we want to engage individuals, not necessarily agencies only, and bringing them to the table, allowing them to discuss, allowing them to share their concerns, allowing them to say what is appropriate. We also talked about, so when we did all of that, we moved into first, in order for that to be successful, we have to understand diversity and understand the need for cultural humility within our agencies. And one thing we talked about was the language that we use sometimes, because a lot of times some of us feel like that we have the cap on certain things, or that we understand, or that there's no room for learning. So we talked about, instead of doing trainings around cultural competence, you do trainings around cultural humility, because competence says I have mastered something, I understand it. But humility says I'm always in a posture posture to learn more, because just because I am African American does not mean I am fully competent of the African American community, because my neighbor's home is different than the one that I was raised in. But humility says that I can learn something different, and if what I learned today changes, by the next time I see this person, I'm in a place to learn, to adjust, to reset, to be able to give them the optimum experience that they need. And then also talking about something that is known by many people, talking about the difference is like equality is not equity. Putting the same amount of benefits into one area and in another area, that's equality, that's not equity. So having those different discussions, we talked about some wonderful tools and wonderful classes that we can that we share with each other to help us understand equity, to help us understand race, to help us understand class. And we're going to form a working group, and we're going to continue our discussion, and we're going to keep talking, and this is going to be wonderful, and we're going to be able to tell you all next year what we've accomplished in a year, and all of our organizations are going to be fully. So thank you.
Wowzers. All right, this is next table. So we got to keep going because we got to make sure all the tables get in so that we don't run out of time. Go.
Excellent. So I get to follow that. Thank you. So we had getting the healthcare system to focus more upstream than downstream. So a lot of similar conversations that a lot of the other tables were having. One of the big things that we came to was the current system, the money is there, but it's all locked up in that kind of archaic fee-for-service system. So how do we get out of that? Who is accountable? So we did have some discussion on who's accountable, and that did not really land anywhere. We couldn't identify any one entity that's responsible for what do we want for healthcare for our country. So we kind of guided the conversation into identifying employers as a potential untapped partner for guiding the funding and the financing for this system to help turn the ship. So they're not the individuals accountable by any means, but it is a kind of a missing partner. And so our by Tuesday task was to maybe get that group, the employers that are purchasing employer-based healthcare coverage, invited to the next national practical playbook meeting. So just a suggestion. And then kind of the longer term was going bottom up and working with our local employers to get them engaged into the table and speaking their language, because it's a completely different language. And it was not lost on us that it's already hard enough to bridge public health and healthcare. So let's just throw in another entity to make it even harder. But that's kind of where we landed with ours. And I think, and then working with kind of the health benefit counselors, with employers, and some more specifics as far as advocacy and getting our message out to the right people.
Thank you. By the way, there are associations or groups of employer-based dialogues that are in fact talking about all this, that are hooked up to the Creating Wellbeing Leadership Group that could be added to the discussion. This was public health and primary care initially with a broader community for this meeting, but it's a really good insight to add other sectors, which actually are self-organized anyway in certain aspects. So they wouldn't be like starting from scratch. It's just that those sectors haven't had as much conversation, as you've pointed out, as might be really healthy. Okay, next table. What's the topic? We're number 9, I believe. 9 would like to pass. How to find helpful people.
Hi, so we had a great time here, and we quickly morphed from how to find helpful people to how to help helpful people be better at our jobs. So we talked a lot about how many resources are out there that we didn't know about, and how to tap into those. We had a great reminder that Google is not everything, and phone calls work great, and quickly kind of started talking about some of the great resources around our table that we could connect people to. But I want to focus on a couple of great solutions that came out of our group. So we talked a lot about what other sectors were doing better than public health. Public health, we have a lot of great stories about cool things that are happening that are very kind of vague, or we have dense research articles. So how to use what is happening in other sectors like hackathons and case studies from IT to really, I guess, learn from other sectors about how they can generate new ideas and innovations. And then also using policy and written templates. We had some great examples of healthit.gov and how you can identify templates and work plans and things that are already out there to really make business cases for public health. And then we talked about internship structures. I think one thing that we talked about is how to link students into health departments and into other agencies, and good ways to do that. Not just kind of take every phone call that comes, but have a structured program, and where might we find those. So County Health Rankings is going to take care of a lot of this for us. I think they volunteered. We also have, I think, if we could have like a single 30-minute orientation for anyone coming into public health that's generated possibly by the CDC. We don't want people coming into public health who don't know about NACCHO or about APHA or about these great national resources. So how do we kind of make that connection right off the bat? Thanks.
Very interesting. Table 10? What's the topic?
Hello. Oh, hi. The multi-sector partnerships. We had a really cool group. So I have notes. So we had at our table we had payers, we had folks from public health, we had folks who are heading up nonprofits and foundation challenges. We had people from hospitals, and we had technologies. And what was super cool is that everybody was involved actively in multi-sector partnerships, in looking for them, in realizing that they were necessary, and in trying to grow these partnerships and look how to move them forward and how can we expand this elsewhere. Our goal as a table was to look at value and impact of these partnerships. What was interesting is that our definitions of values and of impact were as diverse as the people who were at our table. Some people were looking at value as what are the outcomes in patients' lives. Some people were looking at, okay, I know how to track outcomes. How do I look at what that means financially so that I can support this partnership further? So one of our first takeaways is that value and impact mean different things depending on who you're talking to. And when you're constructing a partnership and when you're looking at how to evaluate a partnership, you should take that into consideration. The second part of it was generally that if we're looking at social determinants and if we're looking at multi-sector partnerships, you need to take the next corollary of that, in that if you can't meet everyone's needs in one place, you have to go meet people where they are. So we talked about different folks having different types of information and how to link together all those different types of partnerships and different types of information. There was a lot of sharing of case studies and of work people were doing. And of how they were implementing this kind of work and how we could all learn from each other. One of my original questions when I was looking at this is, how do you really drill down and prove in a financial way, how do you prove the impact that these types of partnerships had? We talked about concentrating on high utilizers and populations like that, where that kind of value is really self-evident when you can cut down and things like that. We also talked about transparency and data sharing. How do you measure outcomes and how do you define them, and how we could all work towards a common understanding of that. And we did not come up with a by Tuesday thing, but we did all promise to talk more and share our outcomes. Hopefully we'll all be working together in the future. So that is our by Tuesday, I think, is to keep this conversation going, talk to more people, and really open that door to meeting people where they are.
Thank you.
I think I got everything.
All right. How many tables do we have to go further? Raise your hand. You got table 1, 2, 3 more or so? Okay, let's go here. So you got about 2.5 minutes. Go.
Hi, everyone. I want to thank Dr. Calvo for bringing the World Café concept to this group. I think it was incredibly effective. Our group was around the deciding database and measuring impact. And we found the deciding database, and we found 2 amazing insights and 3 free resources that we'd like to share with you. So the deciding database is the CDC/NCHS database. The 2 amazing insights is to look beyond the data to the analysis piece, which is really key, and really to couple that with 2 key people. One is the statistician author, and second, a journalist/science writer to create the factoids to bring the data to life. The 3 free online resources that we will check out by Tuesday, and hopefully all of you will as well. The first one is communitycommons.org, which shares logic models for research to make it visible and consensus-driven. The second is pictochart.com, P-I-K-T-O chart.com, which makes instant infographics for your factoids of data. And the third is livestories.com, which brings the human side of data and helps engage others.
Wow, there are a couple words I'd never even heard before.
Hi, so our table discussed physical activity as a wonder drug, and from that we kind of just started talking and posing some questions that we weren't necessarily going to try and answer at the table, but just some more questions to get more dialogue going. And the questions were, where do we start? And I'm just going to highlight some bullet points from each question. So where do we start? And I think the consensus with our group was starting with children would be the most effective and the less controversial, and starting with children and their parents. And then how do we educate? And coming from that is educating children and parents and others on the benefits of physical activity and how it relates to your health. And then how do we implement this? And the big question was who pays for it? Oh, and I want to go back to where do we start? A big part was more research done on physical activity and the benefits. And then so going back to how do we implement who pays for it and physical activity as a covered benefit. And then how do we engage? And it's looking kind of towards your community as engagement and incentives. And then how do we make our community more livable and physically active friendly? And then we discussed what does success look like? And it's not just your clinical measures, BMI, A1Cs, but what does it look like in the community and so on.
So we talked about a lot of healthy housing and innovations, and a lot had to do with when you had older housing stock and older apartments, how to help them to become more healthy housing. And an early comment was that if you just go in with code enforcement, you can end up with properties that end up then being foreclosed and abandoned, which doesn't really help with affordable housing. And so there was a discussion of transitioning older homes or apartments into land banks or limited equity housing co-ops, and then thinking in a more system way to support the residents with training or use of time banking or tool lending that they can help add value to the properties and focus on building social capital to go along with the properties as you're doing a proactive neighborhood building, and used an example of over 200 mobile home parks that have become co-ops and have purchased the land to become resident-owned communities.
Oh, interesting story. So our topic was how to listen to and hear and engage apathetic and adversarial stakeholders. And we came up with the 4 L's. I do want to say our group was tremendous and highly experienced in dealing with apathetic and adversarial stakeholders. And we're able to give a number of great examples on both what their experience was, but also solutions. So we kind of categorize this with the 4 L's that were mentioned earlier. The first is language. Don't start with "you are a bad, ignorant person." It typically doesn't bode well for the rest of the conversation. The second is to listen, and we talked about active listening, which includes repeating what you heard, but also listening for the legitimate points in someone's discussion. So we talked a little bit about listening not only to MSNBC, but listening to Fox News, and see if you can find a truth in both places. The third was finding like-minded goals. Dr. Calvo did a great job of suggesting that for things like obesity, reframing that as a security issue helps folks who may not want to do it just because it's the right health thing to do, but there are other pieces. And finally, it's the last L is longitudinal engagement. So develop a relationship before you have an ask. Do your ask, but then follow up and stay engaged with that person, because that's where you get your authenticity. We also have 5 minutes that we can still talk through to the end. That is to say, what in the share-outs from the different table-type dialogues may have sparked a thought in your head that, that is of perhaps value to the whole conversation in the room. This I often think about as sort of high-energy particle physics, which is to say you crash these ideas together and you don't always know, can't predict what's going to pop out in those high-energy particle physics experiments. And this, to me, feels a lot like this. I had no idea what you guys were going to say. Maybe none of us knew what different people would say. So the question now on the floor is, I'd invite you, if something sparked in your head out of this set of discussions that came up, that you think everybody in the room should at least have a chance to hear. We have a few minutes for that. Otherwise, I would yield the rest of the time back to Lloyd. But I do think it's surprising to me sometimes what pops up. Yes, ma'am. Go ahead.
Hi, I'm Sarah Page from Springfield, Mass., and I was at the housing table. I'm very involved in housing, and just want to add a little bit to what was said and say that I'm hearing a lot about the challenge, especially in urban areas where you have distressed housing, apartment buildings owned by landlords who aren't maintaining them. And I brought up the issue that if you really get aggressive with code enforcement, you can end up with abandoned buildings. But I think there's a strategy that can be developed that our groups across the country could develop into a model and apply in their communities, because it's really low-hanging fruit to get your housing department, your planning department, and code enforcement together to work with you to assess those properties that need work and get your state or your city to allocate a relatively small amount of money in housing terms to then empower landlords to upgrade the property. And that's something that we could develop into a model. I don't think there are yet really good models. There probably are some, but I'm not sure that, I know my city is working on this, but has a ways to go to create a really good model of how to get landlords to do the improvement, because sometimes you're in weak markets where they can't get a loan to upgrade their property because the value is, there isn't the value in the housing, and yet they've got all these code violations that they need to fix. So I would love to work on this issue with people if anyone else is interested.
Super. Thank you. Anybody else? Yes. 2, 3. All right. We'll have these two be the last comments. Go ahead.
Hi, I'm Maria Prince. I've gotten to speak with many of you, and I am one of the, I think I'm the only payer here. If you're a payer, raise your hand. Oh my gosh, I'm so excited because, oh, you are currently? Aetna is a payer that's, I'm with Aetna, and Aetna's looking at transforming our work into, to improve health systems. And I'm here, I'm bargain shopping. I told my people, I'm looking for the best value for PSE, policy systems and environmental change that we can bring to our communities. My background is in public health, and I have this great opportunity so you guys can help a helper, whoever wants to help a helper. I'm actually not in the participant guide, but my email's princem@aetna.com. And I want to bring your best ideas to Aetna. We're ready for it right now. We're moving to have 75% of our spend going through value-based care. And we're not looking at just health care. We're looking at social determinants of health. So you guys help me. Thank you.
Super.
I'm Bill Berman from Denver Public Health, and my insight is a suggested reframing for even how this meeting is titled. So I just looked at the cover of the book, and it says Practical Playbook, Public Health, Primary Care Together. And my suggested framing is to say that the social determinants, et cetera, are primary care's issue is way too narrow. We need to talk about a much broader spectrum of medical care that includes behavioral care, emergency and urgent care, specialty care. If we frame it as primary care's problem, we will have failed.
Fascinating. So I'd like to end by thanking Steph for the willingness to type in front of everybody. Very nice. And Lloyd, we should be on time.
As one of the organizers, I'm always nervous about this exercise, and invariably, he does a great job. So thank you very much.
And let me just add that this meeting is about practical tools and strategies you can take home and use. And this technique that you just saw demonstrated, I mean, that was just a little bit over 2 hours, is one of those tools and techniques. So please, Ahmed makes it look easy. It is not. It is absolutely learnable. Many of you use it in your home communities. If you don't, please learn how to do it, because look what we got done in 2 hours. By the way, Ahmed made a comment which I wasn't expecting about, we're going to talk about how to move from healthcare to health and have fun in the process. I think we did that. So thank you.